Today I'm going to talk about novel prevention and treatment strategies for coronary artery disease. And I guess a bold statement would be that coronary artery disease is a downstream symptom of chronic inflammation and mitochondrial dysfunction. I'm not sure if people would find that controversial, but I think if we're going to make any kind of an impact on this disease, we're going to have to focus in this area. So my name is George Yankos. I work out of the United States. I'm a cardiovascular specialist. I'm board certified in cardiovascular disease and nuclear cardiology. And I also have an integrative cardiac practice for cellular medicine. I'm also a medical director in Long Island, New York, for a wellness center. So I practice both conventional cardiology and integrative cardiology. And I don't represent any hospital. I don't have any political affiliations. I don't have any nationwide medical organization that I'm representing. And I usually treat a variety of cardiac and other inflammatory conditions, utilizing integrative therapies, regenerative therapies, conventional, holistic. I've used ozone and UVBI, LDN, hormone, intensive peptide therapy, and other IV therapies. And during the pandemic, I've also spent a substantial amount of time treating COVID patients and long haulers and the vaccine injured via telemedicine and through in-office visits. So today I wanted to speak about my favorite organ, the heart. And as you might imagine, the heart is my favorite organ. It's an amazing organ. It developed at 6 weeks of embryonic development, and it's the first organ system to form and eventually becomes a complex package of specialized muscles, nerves. Hold on one second. Complex package of muscles, nerves, valves, arteries, veins, and it can beat over 2 billion times in an average lifespan. And it's usually pumping more than 2,000 gallons per day, which is pretty impressive. The heart's an amazing organ. It has amazing capabilities, and it really requires a responsive and abundant supply of blood, oxygen, and nutrients that are supplied primarily by the coronary arteries. And what's interesting is that, unfortunately, the most common cause of death in the world population is a myocardial infarction caused by a disruption in the coronary artery's ability to circulate blood to the myocardium. Coronary artery disease can mean more than just atherosclerosis or hardening of the arteries. It could mean vasospastic disease. It could mean spontaneous coronary artery dissection. It can mean myocardial bridging. And except for myocardial bridging, which is a structural mechanical mechanism of obstruction that you can be born with, other forms of coronary disease usually involve a nutritional, metabolic, inflammatory, or dysfunctional mitochondrial etiology. Also, myocarditis, pericarditis, congestive heart failure, and even trauma to the heart have similar mechanisms of pathology where inflammation and dysfunctional mitochondrial activity could be at the root. So most people usually do not know that they have cardiovascular disease until after an event occurs. In the US, there are around 600,000 people a year that are dying of a heart attack, and that has not changed much since the late 1990s. To put this in perspective, that's the equivalent of 6 747 jets filled with 300 people crashing every day for a year. That's pretty impressive. And for more of a perspective, according to the WHO, since 2019, and these are numbers that I pulled up about maybe 4 weeks ago, since about 2019, there have been more than 1.02 million deaths from COVID. So cardiovascular heart disease has killed more people in the United States than COVID since 2019, and has been doing so for decades before COVID was around. So another 1 million people survive their heart attacks, and nearly half of those develop heart failure. And that has not changed much either since the late 1990s. Aside from smoking, there are other risk factors. Sorry about that. There are other risk factors that we usually try to identify in clinical practice. So we usually look for type 2 diabetes, hypertension, family history of premature coronary artery disease, prior personal history of myocardial infarction, or hypercholesterolemia. And even though these are the most basic things we look for, I think the list is rather restrictive, and I hope to show you that shortly. So the number of people dying from heart disease had dropped from its peak in 1968, and it was attributed to a Surgeon General's report that came out in 1964, advising people of how smoking could be causing cardiovascular disease. And there had been a drop-off. What's interesting, though, is that around 2010, it seemed that we reached a plateau, and whatever benefits we got from that quit smoking campaign didn't seem to bring the curve all the way down. And despite all the advances that we've made with regard to cholesterol control, blood pressure medications, blood thinners, and even procedures, it seems that we didn't really get much better at preventing disease beyond advising people to quit smoking. So unfortunately, the younger population now is adopting vaping, and it's very possible that cardiopulmonary disease might create another surge in these numbers. Next, I wanted to look at cholesterol, which is a very big topic, and I wanted to approach this with what is not usually told to a patient during a cardiac visit. Usually we'll tell them your cholesterol is high, you got to take a medication, but we don't really, as in a conventional practice, really explain the significance of cholesterol. And so my question, or the question that usually arises when I have this conversation is, what is cholesterol? Do we need cholesterol? Is cholesterol bad? So the first thing I try to tell people is that cholesterol is not a fat. It's the mother of all hormones. It includes sex hormones and vitamin D. LDL is not bad cholesterol. It's a lipoprotein. It's a micellular-like protein that carries cholesterol and other fat-soluble compounds into tissues from the liver. And LDL carries essential nutrients. It actually carries vitamin A, EPA, DHA, fats, vitamin E, vitamin D, vitamin K to organs and systems that require these nutrients and substances. Genetic and dietary factors can increase LDL, but messages from the brain can signal a heightened need for cholesterol synthesis for hormone production or to carry essential nutrients. So HDL is not a good cholesterol. It is a lipoprotein also, and it carries and transports oxidized fats and excess fats back to the liver for recycling and reprocessing or disposal. And triglycerides are fats or lipids, and they're found in your blood, and your body converts any calories it doesn't need to use right away into triglycerides. The triglycerides are stored in your fat cells, and if you regularly eat more calories than you burn, particularly easy calories like carbohydrates and simple sugars and fructose, you may have high triglycerides. An interesting little tidbit is that if your fibrinogen is ever increased, which is usually a signal for repair, this signals the liver to produce more cholesterol and LDL, which I find extremely interesting. In these circumstances, cholesterol is acting like an acute phase reactant and is probably involved in a repair process. So cholesterol moves through the bloodstream by means of lipoproteins. LDL shuttles cholesterol and other molecules away from the liver to where it's needed. HDL shuttles molecules back to the liver for reprocessing or removal, and distance signaling can influence cholesterol and LDL levels. I think that's something that I try to relate to the patients. So are there any benefits to cholesterol? Cholesterol is produced in the liver, and over 70% of cholesterol is used to produce bile acids. And bile acids, their job is to neutralize stomach acids and emulsify fats. They're innately inflammatory and are usually converted downstream in the intestine to anti-inflammatory TUDCA, or ursodeoxycholic acid, and that usually happens in the setting of a healthy gut biome. Cholesterol production is regulated by the brain through effects on the liver and its ability to synthesize cholesterol. And it's very important to relate to everybody that the liver makes more cholesterol than you ever ingest through food. Key point, if you're not moving bile, you can increase cholesterol levels upstream. So how do you move bile? And you move bile by making sure you're having adequate bowel movements. I know that sounds strange, but we'll go into that in a little bit more detail. Cholesterol is also important for hormone production. As we discussed before, it's the mother of all hormones, and it's responsible for producing cholesterol, sex hormones, even vitamin D. And they can increase if you're not producing sex hormones. Since you're not using that substrate, there's going to be more cholesterol around. And cholesterol is needed for production of new cells, for the membrane integrity of cells, and for transcellular membrane communication. So cholesterol has a significant and beneficial role in our bodies. The human brain is nearly 60% fat and contains an inordinate amount of cholesterol. 25% of all the cholesterol in the body is in the brain, while the brain only represents 2 or 3% of your body mass. And that's pretty impressive. The Alzheimer's patients have been found to have only 1/6 of the concentration of free fatty acids in their cerebrospinal fluid compared to people who don't have Alzheimer's. And cholesterol has been shown to play a critical role both in nerve transport in the synapse and in maintaining the health of myelin-sheathed nerve fibers. So both a low-fat and statin drug treatment will increase the susceptibility to Alzheimer's. And elevated triglycerides were associated with better memory function. So there's also non-cardiac impact of low cholesterols. The conventional practice is that if you have coronary artery disease, then your cholesterol has to be dramatically lowered to prevent future events. And the initial major research focusing on heart disease, cholesterol-lowering drugs, was on middle-aged men with severe cardiovascular disease. These studies don't really translate to women, and cholesterol lowering has the opposite impact on the elderly and younger people with serious diseases, meaning a non-beneficial impact. So a low serum cholesterol is associated with a variety of non-atherosclerotic diseases. In studies, men under the age of 50 have a significantly higher rate of infection if their total cholesterol is less than 160. Excess risks of AIDS and age-related death. Cholesterol apparently has a protective effect over our bodies against viruses and other infectious species. In a study titled Lowering Cholesterol Concentrations and Mortality, a quantitative view of primary prevention trials, there seemed to be a connection between low cholesterol and a higher likelihood of early death. This was especially true in women for whom moderately elevated cholesterol by current standards might prove to be not only harmless, but even beneficial. Looking at mortality statistics, there seems to be a U-shape to the mortality statistics. So people with higher cholesterols overall have a lower overall mortality. People with high cholesterols at the far end, usually greater than 300, usually probably need to be lowered because there is some increased risk for mortality or events. But a level of approximately 250 milligrams per deciliter, and in some places you'll see quotes of 225, somewhere in that range is probably ideal in terms of annual mortality risk. So older people have guidelines. In other words, if we get older people to where our current cholesterol lowering guidelines are about, they have a 275% more, they're 275% more likely to die compared to people who have higher cholesterols around 250. And there's been a lot of studies showing this inverse relationship between cholesterol and mortality. When we as physicians say high risk, it makes me wonder when you see these things that do we really mean high risk for not living a long and healthy life if we treat you? I'm not saying that in a joking manner. I think we have to consider this data. And a very low cholesterol is associated with mood disorders, violent deaths, an increased risk of infection. Women with elevated cholesterols have lower morbidity and mortality. In men, elevated cholesterols has a neutral effect. However, low cholesterols are associated with a higher all-cause mortality. Effectively lowering cholesterol does not correlate with improved outcomes when looking at all-cause mortality, as we said. In familial hypercholesterolemia, obviously if the numbers are over 300, it's one thing whether you have familial hypercholesterolemia or not, but it may be the propensity for thrombosis and not the cholesterol that increases the risk for events. So cholesterol is also a substrate for sex hormones, and a low cholesterol often leads to a low testosterone level. So low testosterone levels increase the all-cause mortality and cardiovascular risk. Low testosterone levels increase the risk of coronary artery disease, metabolic syndrome, type 2 diabetes, and people with congestive heart failure have a worse prognosis. And when you put people on testosterone replacement therapy, you can see improved myocardial ischemia in men with coronary artery disease, improved exercise capacity and heart failure, reduced insulin resistance, and improvements in the hemoglobin A1C. And it's one thing to replace it artificially, but obviously, if we're removing the substrate, that could be a reason for testosterone going down. So the question, I guess, should be is, do we want to drop testosterone levels if cholesterol is being tied to that? And another interesting question is are we replacing testosterone in cardiac patients when their testosterone levels are low? So cholesterol readings are increasingly used as a quality indicator in clinical practice, and it actually impacts on how much physicians are being reimbursed. At least this is in the United States. I'm not sure if that's the case in the United Kingdom. But so is cholesterol an enemy? So if half the people who die from cardiovascular disease do not have an elevated cholesterol, so when people with heart attacks die, shouldn't it be a mystery if high cholesterol is the usual cause? I think that's a question to ponder. And less than half the people who die from a heart attack had high cholesterol. Lowering cholesterol is supposed to be an attempt to reduce our cardiovascular deaths, and new guidelines for the management of cholesterol increase the number of adults who would be eligible for statin therapy, with the increase seen mostly among older adults without cardiovascular disease. So are stricter guidelines for cholesterol a way to make more people fit into the cholesterol model because we have failed to improve mortality statistics is a question that comes to my mind when I see these things. So is cholesterol a cause or a marker? You might be thinking, but George, you're not talking about HDL and LDL. That's where we want to focus. And although HDL at high levels is associated with a low incidence of coronary heart disease, 50% or more of people who experienced their first heart attack did not have a high cholesterol, and they did not have suboptimal HDL levels. So is it wrong to say that cholesterol-lowering drugs do not reduce cardiovascular disease? In the New York Times, they wrote a big article called Dashing Hopes, and it was a study that showed cholesterol-lowering drugs had no effect on heart health. 12,000 patients were studied, and comments from the American College of Cardiology annual meeting stated we had an agent that seemed to do all the right things. It's the most mind-boggling question. How can a drug that lowers something, is associated with benefit, and still shows that it doesn't have any benefit? The study at that time had actually shown a 37% drop in LDL levels with the drugs and yet no significant impact on cardiovascular disease or death. And is it because cholesterol is associated with heart disease and it's not actually the cause? And I think that's a question we have to ponder further. So is cholesterol playing some other role? Is it there to protect us from disease? Signaling from fibrinogen supports this idea. Elevated triglycerides have been associated with heart disease also, and usually with numbers over 500 milligrams per deciliter. And usually any numbers below that, you can bring triglycerides down pretty easily just by focusing on the glycemic index of foods, omega-3 fatty acid supplementation. But obviously, very high levels of triglycerides can cause vascular disease, and it could be because of inflammation that's being induced by some form of insulin resistance. Cholesterol has long been thought to be the culprit and one of the initiating factors in coronary artery disease through its interaction with the endothelium. And the endothelium is an amazing, the inner lining is almost like an organ. It makes up 14,000 square feet, could take up 6.5 tennis courts, and the surface has some control over vasomotor tone, growth of new vessels, and fat oxidation. Stress affects endothelial function through adrenaline. Nitric oxide plays a major role in endothelial function. But we need to remember that coronary arteries are not just endothelium. They include microvasculature and bioactive layers that are behind them. Just going to take a little drink here. So here you're going to look. The adventitia is the outermost layer of the vessel wall, and it contains a heterogeneous population of cells. It includes macrophages, T cells, B cells, dendritic cells, progenitor cells, and fibroblasts. And these can all differentiate into myofibroblasts. Hypertension can affect this adventitial layer because wall stress has the ability to increase the adventitial matrix. The adventitia also includes components of the adrenergic nervous system, the lymphatic network, and what I want to focus on is the vasa vasorum, a specialized microvasculature which runs on and through the adventitial layer and at times deep through to the intima. So the vasa vasorum play a major role in normal vessel wall in biology and pathology. And the function of the vasa vasorum is both to deliver nutrients, oxygen to the arterial and venous walls and remove waste products either produced by the cells in the wall or introduced by diffusional transport through the endothelium of the artery or vein. And they can transport products directly from the aorta as well, where the vasa vasorum originate. They expand in response to injury, which alters vessel homeostasis. Their patency is modulated in reaction to surrounding compressive forces within the vessel wall and due to variable tone in the smooth muscle within the proximal vasovasorum, which is impacted by blood pressure. They proliferate and grow to meet the nutritional needs of the artery's outer layers when metabolic needs exceed the amount of oxygen that's coming from the luminal side. And they begin to sprout before aortic wall thickening, and that sprouting is in turn preceded by the presence of inflammatory cells in the adventitia. So one model suggests that adventitial inflammatory cells secrete a number of angiogenic growth factors, including vascular endothelial growth factor. So in monkey studies, there was a large increase in blood flow through vasovasorum and atherosclerotic coronary arteries. That increased flow is produced primarily by proliferation of new vessels that originate from the adventitial vasa. So the view that inflammatory cells contribute to angiogenesis in atherosclerotic plaques is supported by observations that inflammatory leukocytes correlate with regions of vasovasorum proliferation. Initial neovascularization is seen more at sites of inflammatory cell infiltration than in calcified or hyalinized plaques. So there is a relationship between the vasovasorum characteristics and the development of atheromatous plaques. It's pretty well documented, but it's not clear if they are causative or merely reactive. However, even if these are proliferations that are merely reactive, these new microvessels may be a source for disease progression by virtue of endothelial impairment and as a pathway for monocytic cells to migrate to sites of early disease in the endothelium. So the vasovasorum are responding to chronic angiogenic responses due to local cytokine accumulations that occur in arterial and coronary arterial walls and regular arterial walls in the presence of hypertension, hypercholesterolemia, accumulation of lipids, extravasated blood products, in other words, leaking that might be occurring from this extravascularity, which attract monocytes. And plaques demonstrate an underlying elevated microvessel density, inflammatory cell content, and intraplaque hemorrhage. So why are we talking about the vasovasorum? There is enough information to support that the primary cause of atherosclerosis is the reactivity of the vasovasorum resulting from and resulting in cytokine release from the adventitial layer. This can just as easily be the mechanism behind plaque aggregation at certain foci in the coronary arteries. So is plaque secondary to inflammation? Is plaque not inflammation, as we've been led to believe all these years? And is our current strategy treating the root cause? Or is coronary artery disease a downstream symptom of chronic inflammation and mitochondrial dysfunction that leads to leaky microvasculature that your body is trying to contain? Which came first, inflammation or plaque? And is cholesterol causing inflammation, or is it the body's way to respond to inflammation? Clearly LDL and oxidized LDL are part of what makes up the coronary plaque, but is it causing the plaque? Is plaquing detrimental or reactive to the real cause of coronary atherosclerosis? And there is an outside-in theory that was put forth by Ufi Ranskoff, whereby vascular inflammation begins in the adventitia and advances to the media and the intima. And the theory opposes the long-held inside-out concept that monocytes infiltrate the vessel wall from the luminal side. And it really should make you wonder, is LDL being sent to form a plaque because that's the problem, or is it trying to wall off some sort of toxicity that's going on underneath? And among the arguments that sort of support this is that there are resident immune cells in the adventitia, and this is the home of many macrophages that can lead to the disease process that we've been describing for coronary atherosclerosis. So a dysfunctional endothelium is one of the initial signatures of early atherosclerosis, but the alteration could just as easily come from the outside in and not the inside out. So the point being, if cholesterol model of atherosclerosis progression doesn't make sense and the therapies aren't altering outcomes, but just lower cholesterol numbers, then is LDL cholesterol the cause of the disease, or is it there reacting to an underlying process, and is it acting as a protective mechanism? In the end, if we want to make an impact on the costly and deadly CAD pandemic, we should probably consider going beyond lowering cholesterol. We've spent 30 years chasing one cause of cardiovascular disease. The numbers suggest we are not looking in the right place, given the plateau that we've hit since the quit smoking campaigns. And if we really want to make an impact on the #1 killer in the world, we need to potentially look somewhere else. And it may be that the plaque is the body's defense against some sort of inflammation going on underneath, being triggered by microvascular events and leakiness behind the plaque. And in essence, LDL cholesterol is acting as part of the immune system. It's sequestering harmful pathologic processes and harmful pathogens. And I guess my bold statement is plaque is not formed because of your diet, genetics, or aging. It may be the result of a toxic incident that your body attempts to nullify through inflammation. And it's when this inflammation goes on unabated, because we're not treating the root cause, that we see the cascade of events we described in the picture here. So these are the conventional therapies that we usually use for lipid lowering. So we're going to look at statins first. And millions of Americans are on statin drugs today. And the statistical data shows that statins do reduce cardiovascular mortality in middle-aged males with severe disease, but only slightly. However, all-cause mortality is not reduced significantly at all. And the Harvard Medical School Proto magazine had written that what statins might do for you. They can lower your cholesterol, they can reduce your risk for cardiovascular disease, they can cause muscle pain, fatigue, fail to significantly prolong your life. So statins don't seem to confer the ultimate health benefit, longer life. And their last statement was, so lowering cholesterol is not as important as everyone has been led to believe. Cholesterol is not the cause of cardiovascular disease, but inflammation is. So lowering cholesterol does not reduce heart disease, but lowering inflammation does, according to the Harvard Medical School Proto magazine. So statins, I wanted to go over some facts, benefits, side effects. So statins are a multi-billion-dollar class of medication for pharmaceutical companies. And current therapies and guidelines aim for extremely low cholesterols, and we're including larger and larger swaths of the population into this cholesterol lowering model. And you need to treat about 140 people to prevent a single heart attack or a stroke without any overall reduction in death or serious illness. And when I hear that, to me it says, well, I ask myself, is less than 1% effectiveness a good standard of care to follow? And statins have some utility in the treatment of cancer. Half of the people who get sick from cardiovascular disease are being ignored by the statin cholesterol health model. Statins have played an impressive, they've displayed an impressive relative risk reduction, but they have a minuscule reduction in the absolute cardiovascular mortality. And two well-done meta-analyses for statins for primary prevention showed no mortality benefit, with small reduction in all-cause mortality associated, sometimes being seen. So another property of statins may be at the root of the mineral effect. Statins do have anti-inflammatory properties, and surprisingly, they also have antibiotic properties, much like macrolides. So I guess that can bring up a question: is there an infection at the root of coronary artery disease? And if there is, would you take an antibiotic for life if that's the mechanism through which statins work? So there is there's scant scientific evidence supporting the use of statins by 70 and 80-year-olds without pre-existing cardiovascular disease. And there can be some harm tied to statin use in the octogenarians with an increased risk for developing cataracts. And we could talk about what that means in a little while. Statins may block the benefits of exercise. They can cause a range of diseases with little or no benefit in women. The Women's Health Initiative had shown an increase of 48% in the risk of diabetes among women receiving statins. So since diabetes is a major cause of heart disease and premature death, maybe women should be taken off of statins, especially when it's being used in a primary preventive manner. Side effects include myositis, myalgias, liver inflammation, cancer, dementia, precipitation of diabetes, autoimmune disease, confusion. They're known to block CoQ10 production, which is a fuel that's important in mitochondrial function. And interestingly, CoQ10 deficiencies can lead to heart failure, hypertension, myositis, myopathy, neuropathy, and achiness. So in a patient population, the older patient population that's already having problems with mitochondrial function, this creates more issues. By reducing cholesterol, the substrate for cortisol and other hormones could be reduced as well. And I think we covered that on a previous slide. So what other therapies are there? There are these PCSK9 inhibitors. There's a small interfering RNA, which is a relatively new medication on the market. There's ezetimibe and fenofibrate. And PCSK9 inhibitors are very potent at lowering your LDLs and are meant to be used with maximal tolerated statins and ezetimibe. But clinically, because due to intolerances to statins and ezetimibe, they've been used in isolation with pretty good results in lowering LDL. But like statins, there may be some success in secondary prevention, but there really hasn't been a lot of research for primary prevention in using these medications. Zetia and fibrates have their uses for lowering LDL and triglycerides, respectively. MicroRNA technology, the Leqvio that's out there now, or the inclisiran, is, to me, I have a lot of reservations in using these agents. They can dramatically lower your LDL. It's a twice-a-year therapy. But really, I don't think there's enough clinical data, especially post-marketing clinical data, to know what this is going to mean. I'm not sure that lowering your LDL very low and doing it for a long period of time is a good idea. And in a twice-a-year therapy, I would like to see people on these medications for many years before I would feel comfortable prescribing something where I won't know the side effect profile. So I spent a lot of time on cholesterol today, and I'll spend a lot less time on the other factors that precede coronary artery disease. But I think it's important that inflammation is a key process here. And when it comes to diabetes and hypertension, inflammation also plays a role. And if we really want to make an impact on coronary artery disease, I think we need to allow for appropriate inflammation and allow for recovery from inflammation and do things that will help promote these kinds of activities. So another risk factor is type 2 diabetes, and that's really a spectrum of glycemic control, from insulin resistance to hyperglycemia to prediabetes, type 2 diabetes, and obesity. And insulin and really chronically elevated sugars, even before having clinically diagnosable diabetes, has ravaged the American population. Over 79 million Americans over the age of 20 have prediabetes. Up to 70% of them will go on to develop diabetes, and 90% don't even know that they are at risk. As many as 28% of the population with full-blown diabetes don't know they have it, according to the CDC. Slightly elevated glucose is tied to heart disease, Alzheimer's, prediabetes, diabetes, and premature death. From a cardiac perspective, there is a significantly increased risk for developing clinically significant atherosclerosis in this spectrum, but the standard of care testing may be delaying appropriate preventive care. So fasting serum insulin elevates months or years before glucose even goes up. Fructosamine and hemoglobin A1C, which are two markers that we use commonly in practice, can gauge your 1 month sugar, your average glucose levels 1 month before that blood test, and 3 months before that blood test, respectively. And all three are markers of insulin resistance, but fasting serum insulin is a better early marker for metabolic disease and risk for diabetes. And I think that's something that should be incorporated into everybody's practice, is to check fasting serum insulin levels. Chronic inflammation is a key component in insulin resistance and eventual obesity. The ACCORD study, which stands for the Action to Control Cardiovascular Risk in Diabetes, had shown that very tight glycemic control can be associated with significantly adverse events in diabetics. And I think I wanted to bring that up. Unlike what we do with cholesterols, very low sugars definitely is not something that we want to do. And it's been shown that people will die earlier if we follow that. There are some advantages to uses of metformin, which have been showing some additional benefit in reducing the risk for cancers through its anti-inflammatory effect. And there should be consideration in using GLP-1 agonists or SGLT2 inhibitors in diabetics, given their additional cardiovascular benefits. So hypertension, we're going to talk quickly about that. So whether it's the direct endothelial trauma or adventitial signaling that leads to the inflammation ending in the presence and the progression of a plaque, it's clear that high blood pressure does play a role. And clinically, I guess one of the things that I face a lot is how high is a high blood pressure? And it's clear in the elderly population that lower is not better when it comes to the blood pressure, unless there's some sort of a structural mechanical condition in the heart that really warrants lower blood pressures, or if somebody has a cardiomyopathy or congestive heart failure. But in the older population, tight blood pressure control is a source of a lot of ER visits here in the United States, a lot of injuries. There does seem to be a higher preponderance of orthostasis in the older population. So when you really go for tight blood pressure control, you'll find people passing out, getting dizzy, losing balance, and hurting themselves, and even head injuries can happen in those kinds of circumstances. So interestingly, blood pressures, could they be due to a deficiency? And it turns out that magnesium deficiency, of which humans have a lot of, CoQ10 deficiency can cause hypertension. And interestingly, the medications that we use to treat blood pressure and cholesterol can cause deficiencies in magnesium and CoQ10. So a lot of times the treatments that we're using are exacerbating the problem. So there's a true cost for use of pharmaceuticals, and it's not, and I'm not trying to measure something by the price of the prescription. So when you're treating the signs and symptoms of disease and not the root cause, there's an ever increasing need for more inhibitors, more blockers, more monoclonal antibodies, mRNA therapies, and these things are being initiated far after that initial insult that's causing clinically significant disease, in my opinion. So and what we do as clinical doctors is we're really managing side effects from the medications that we prescribe the majority of the time. So we know what the side effects are, but do we know that they're creating nutritional deficiencies? And most of the time, these patients are continuing to use medications, and we're not successfully repleting these deficiencies. So statins can block CoQ10, and like we said earlier, it can lead to heart failure, hypertension, Parkinson's type symptoms, myositis, myopathy, neuropathy, achiness, and CoQ10 again is essential for normal myocardial function. Metformin also reduces CoQ10, B12, folate. Diuretics reduce, as we all know, potassium. Most of us should know magnesium, reduces calcium, reduces vitamin B1, which can have a significant impact on cardiac function, and CoQ10. ACE inhibitors and angiotensin receptor blockers can cause zinc deficiency, loss of taste and smell, increased salt and sugar cravings. And of course, I want to touch base on aspirin, not so much of a side effect, but a risk of using these things is that there's a great benefit in using aspirin because it will reduce non-fatal MIs in people who've had previous events. But the studies that showed this primarily used buffered aspirins. And I don't really see a lot of people using buffered aspirin when they're recommending aspirin to their patients. And buffered meaning that it contains magnesium and calcium. And over the years, aspirin doses have been gradually getting pulled back and reduced because of associated bleeding and fatalities. It's really only being recommended for secondary prevention at this point. So from a pragmatic perspective, when I get somebody in my practice that's already on medication, my rule of thumb is once you go conventional, you have to go all the way and slowly back off medications as you work to reduce the root causes of inflammation. And a lot of times when you do treat the root causes of inflammation, you'll find that people can come off of a lot of these medications or go on significantly lower doses. So as a cardiologist, and as all cardiologists, we study the heart and scrutinize every aspect of its function, because without those functions, we can't live. And it's easy to forget in the world of echocardiograms, nuclear stress tests, cardiac catheterizations, pacemakers, defibrillators, that the heart is not necessarily the origin of heart disease. So we shouldn't forget to look at the whole person and not just the heart is the point. So what is the source? So if current technology and medicines have not made an impact on all-cause mortality, are there alternative causes for coronary artery disease we are not identifying, treating, or preventing? And given the lack of progress, we have to stop, step back, assess, and think about what is missing and what can be done better, and what is the root cause of this health epidemic. A convenient crutch for a lot of us these days in this modern era is to believe that our destiny is mainly controlled by genetics, and I don't think that's true. Environment is more important than genetics. And one minor example, there are people that have a strong genetic predisposition for Alzheimer's, and they tend to comprise only 2% of the sufferers of Alzheimer's disease. So obviously the environment is playing a role there. And Claude Bernard, often called the father of the concept of internal balance, stated that the experimenter who does not know what he is looking for will not understand what he finds. So could modern medicine be looking in the wrong places for problems being caused by chronic disease? Complex chronic disease is never triggered, never prevented or cured by targeting a single factor. Like cholesterol, blood pressure, or diabetes. Our physiology is too complex and disease is non-specific. So do we need to bring the body's functions into balance, achieve homeostasis so the body can heal itself to make an impact? Are there alternatives to the current blockers, inhibitors, monoclonal antibodies, stents, bypass? So inflammation is at the center of all healing and disease processes. It can be, for lack of a better word, good, or it could be bad. And a reaction of a part of the body, so the definition, if you look up inflammation, is a reaction of the part of the body to injury or infection, characterized by swelling, heat, redness, and pain. And the reaction includes increased blood flow, influx of white blood cells, chemical substances that facilitate healing. And what I want to add is that when inflammation overwhelms the body's ability to douse the flames is when chronic inflammation leads to autoimmune disease, cancers, dementia, and cardiovascular events. So this is a list of diseases that have been linked to chronic low-grade inflammation, and it could be anything from arthritic symptoms to cardiovascular disease, cancer, diabetes, mood disorders, sleeplessness, eye disease, stomach-related issues, cognitive impairment. So mitochondria play a key role in trying to keep things in balance. They are important organelles. They're functionally versatile organelles. In addition to their conventional for meeting the cell's energy requirements, where they house what's needed, the machinery for glycolysis, beta oxidation, and the energy produced by the electron transport chain. The mitochondria also actively regulate the innate immune responses against infectious and sterile insults. Proteotoxicity is a term that talks about damaged or misfolded proteins in the cytoplasm of the cell, and these could be organelles that are damaged. And at the cellular level, the ultimate outcome of uncontrolled or severe proteotoxicity is cell death. And when there's a lot of oxidative stress and it becomes overwhelming, components of the mitochondria can also break down and can be released and exposed into the cytoplasm. And this could actually trigger an innate immune response. It turns out that even the innate immune response has a huge reliance on mitochondrial function, and the mitochondria can regulate what kind of signals are being sent out by these white blood cells. They're literally serving as a hub for vital cellular processes. So normal mitochondria are involved in biogenesis, autophagy, apoptosis, and maintaining and restoring organelle homeostasis to safeguard organelle integrity and functionality. So defective mitochondrial function is more likely to occur in chronic low-grade inflammatory states, and it stands to reason that supporting the mitochondria's health is tantamount to supporting our own health. So mitochondria make up 40% of the myocardial cellular matrix, very important. And there are around 5,000 mitochondria per myocardial cell, yet there are about 10,000 mitochondria per brain cell. So that's pretty impressive. The brain needs a lot more energy than the heart. I would have never believed that when I first read this. And I think one important thing to understand is these mitochondria are in every one of your cells. And maybe a key point that I'll focus on a little bit more later is that snacking in large meals increase the likelihood of mitochondrial dysfunction because there's a lot more oxidative stress. And we'll see how this figures into recommendations later. So this is what I call the ramp of inflammation. There's many causes of inflammation. As you can tell, it's not just infectious etiologies that can act as stressors. So inflammation is good up to a certain point, but the moment the oxidative stress and the immune reactions associated with normal mitochondrial function become overwhelmed, that is when chronic inflammation becomes the source of all major illnesses. So reducing the amount of inflammation that your body is exposed to, and reducing the amount of inflammation that your body needs to quell, and supporting your body's ability to quell this inflammation is really at the heart of cellular medicine, and probably holds the key to making a major impact on many illnesses in the world. So what are the hidden causes of cardiovascular disease? So there are chronic stealth or cryptic infections that could be initiating these inflammatory responses. Chlamydia pneumoniae, which is a very ubiquitous infection, an intraepithelial organism that has multiple phases, sometimes hiding inside cells, sometimes going into the bloodstream. They mimic mitochondria, they hibernate, they relapse, and they live in biofilms in the gut, in the gums, in plaque. Borrelia is another organism that could be cryptic and long-lasting. Bartonella, lipopolysaccharides, which usually are being released through the death of gram-negative organisms or endotoxin, can also cause inflammatory conditions, and they've been implicated in leaky gut and leaky gums. Antibiotics, through their effect on the gut biome and how they alter mitochondrial function, could also create problems and inflammation. Parasites, toxicities related to heavy metals. Another key point, parasites love to feed on the heavy metals, and when they do die, they love to burst them and release them in large doses when that happens. So always got to be careful when you're treating parasitemias or parasite disorders. There's also metabolic and genetic issues, hyperhomocystinemia, hyperinsulinemia, hyperglycemia, and gluten can play a big role not only in gluten enteropathy, but on the heart directly. EMFs are not really talked about enough, but they can definitely impact mitochondrial function. Excuse me. They can definitely impact mitochondrial function. And then stress and altered circadian rhythms play a major role on normal myocardial function. So a key thing to focus on here, and I always tell people to focus on their dental health in my cardiac practice. So the oral flora are among the most common oral culprits for chronic inflammation and vascular plaquing. Oral bacteria have been found in plaques of arteries. The culprit bacteria can be P. gingivalis, Treponema denticola, T. forsythia, Fusobacterium, and also the chlamydia that can live in your biofilms in your mouth. All of these organisms love to thrive in acidic environments. So type 2 diabetes, tobacco use, E2H use, these also create acidic environments. And interestingly, there's a high prevalence of gum disease. So at age 30 to 65, 47% of the population has gum disease that could be inducing these inflammatory cascades. And people over the age of 65, about 71% have gum disease. And this is what I call leaky gums. So you can go to the dentist and you could try to catch this early so that you're reducing these inflammation-inducing events. So, a lot of people go to the dentist, they probe your gums, and you're looking for deep pockets, which could be one of the first signs that there's gingival disease. And some interesting little factoids about the teeth. Root canals have been associated with an increased risk of cardiovascular disease. There's a 530% increased risk for MI after root canal versus pulling a tooth. And I got to tell you, that's pretty scary. And I would say about 50% of the time when I'm talking to people in the hospital after their heart attack, they had recent dental work. And that's been shocking to me. And then we always have to remember about toxicity from amalgams. A lot of people have gotten metal put in their teeth, and there can be some long-term toxicity related to that. So the heart, the pancreas, the kidneys can all be impacted by oral health. And one thing I wanted to bring up is fluoride. That's a big thing. We, in the United States, at least, fluoridation of water is a very common practice in a lot of cities. And interestingly, there's been studies that have shown no difference in tooth decay or missing or filled teeth in children who drank fluoridated water versus children who didn't drink fluoridated water. And if you're to think about the toxicity that fluoride can cause on bones, brain, and the thyroid, makes you wonder if we should be continuing that practice. Gluten and the heart. So all grains have gluten. Gluten is a family of storage proteins found in grass, wheat, barley, rye, oats, corn, and even rice to some extent. It can cause celiac disease or the gluten enteropathy, but also it can cause a non-celiac or non-enteric gluten sensitivity. And when you see it, it'll cause an acute pericarditis through an autoimmune reaction. And it's unclear through which toll receptors, but glutens are known to affect toll receptors and lead to NF-kappa B activation and leading to a whole bunch of cytokines being released. And gluten can cause vascular inflammation. And there seems to be some sort of a genetic predilection for gluten to cause cardiac issues in people who have HLA-DQ alpha 1 or HLA-DQ beta 1. So how do you assess inflammation? So we take a rather expansive history. It's something more on the, at least in my practice, I take more of a functional medicine evaluation where I'm getting very detailed diet tolerances. I talk to them about how food's prepared, whether they've used antibiotics, steroid use, their dental condition, emotional state, stress, relationship, because we're really trying to capture these factors that can lead to a higher inflammatory state. On the physical exam, we can do the typical heart exam, but we're also looking for the body mass index, what type of obesity somebody's manifesting, whether it's heart-shaped or apple-shaped. We look for body fat composition, and in people who have the equipment, we also look for visceral adiposity using devices like the InBody, which can be very helpful not only to talk about people's risk for developing type 2 diabetes, but when you're treating them and they're getting to do the right thing, you're going to see changes in visceral adiposity before you see changes in the scale at times. Let's go over these in a little bit more detail. So an ophthalmologic exam is one of the things that I recommend when people are coming to my office, and the eyes are the window to your inner self. So this is the only place in the body where you can see a bare nerve, a bare artery, and a bare vein without doing any cutting. And the disease processes that you see in the eye are probably occurring in the rest of the body. So a famous study, the age-related eye disease study, which was a prospective study, identified that glaucoma was really the equivalent of microvascular disease, and it was usually caused by a focal infection or inflammation of the choroid plexus. And much as Alzheimer's is a vascular disease in the same way, it's been nicknamed the Alzheimer's of the eye, and Alzheimer's has been nicknamed the glaucoma of the brain. And periodontal disease can be closely tied to glaucoma. Cataracts, which are typically amyloid deposits in the eye, which are abnormally folded proteins that act as antimicrobial peptides that form in response to inflammation or an infectious process. So what you're actually seeing in cataracts is supposed to be a protective mechanism. But what's clear is that many people go to an ophthalmologist, they'll find cataracts, they'll schedule them for surgery, but I don't think many of these patients are being told that, guess what, 11% of patients have a higher risk of dying of cardiovascular disease in the next 6 years. And I have to tell you, I think it's rare that I get a referral from an ophthalmologist after they've done cataract surgery. And that should probably be happening more often. Macular degeneration, and it's very similar to cardiovascular disease risk when it comes to cataract disease. The same thing can occur with macular disease. So when they identify these drusen bodies, which are usually seen with dry, like macular degeneration, that's actually an amyloid plaque in the choroid. So when these things are being seen, people should be undergoing cardiovascular evaluations because of some inflammatory process that's already been going on for some time. And of course, one of the new technologies that are being used by optometrists and ophthalmologists everywhere is the optical coherence tomography, which is basically a sonogram map of the retinal nerve fiber layers. And it turns out that the thinner these layers are getting, the more inflammation is present, and you have a higher risk for Alzheimer's and cardiovascular disease. So we talked about this already. Again, the apple-shaped obesity being tied to metabolic syndrome. And when it comes to diagnostic testing, when I'm seeing somebody in the office and they're having any kind of symptoms, they're going to be undergoing an evaluation to make sure that this person is not at risk for an acute event. So we always want to rule out acute issues. And that's where these EKG stresses, nuclears, echoes, CAT scans, and catheterizations can really make a big difference. But in the asymptomatic person, it really depends on your age and risk factors. And in my opinion, what their inflammatory risk is, which we can go over how to assess that. I wanted to also point out this gentleman on the bottom frame. He's wearing something called a PNOE, which is basically a miniature CPET that many people in the wellness community are starting to use, where you could actually find what your target heart rate is for peak fat burning. And you could also track your progress as you're improving. That should change. So that's a pretty impressive piece of machinery, yet pretty expensive. So how do you assess inflammation? Lab work, obviously. Although there's many standard labs that are powerful in identifying hidden problems, if we're to make a stellar attempt to preventive strategies, we should include stool testing, where we're not only assessing gastric function, pancreatic function, but we're looking for dysbiosis, leaky gut, small intestinal bacterial overgrowth. DNA testing should be considered also. These single nucleotide polymorphisms that can change how each person metabolizes things or detoxes from things is an important bit of information if we're going to do the best job for our patients. We could also assess how efficient their glycolysis, beta oxidation, and their mitochondrial function is with certain tests, food allergy testing, and then something that I put together is called the Somatic Inflammation Index, which is really a large variety of inflammatory markers. And they reflect cytokine activity, acute phase reactants, breakdown products of cell walls, mitochondrial dysfunction, markers of insulin resistance. And I put these all together to assess how inflamed somebody is when they're coming in, really asymptomatic, but looking to stay healthy in the future. So to discuss the significance of a few of the tests that we do on the inflammation index, one of the things that we do is a homocysteine. And I think a lot of people do this, and it should be less than 9. It's an independent risk factor for inflammation, heart attack, CVA, cancer, diabetes, and bone loss. Lowered B vitamins, which are cofactors for methylation, can actually lead to homocysteine elevations. Fibrinogen, again, a signal molecule for inflammation. A complete blood cell count, that in and of itself could be very powerful. And it's been surprising to me that patients with chronic white blood cell counts greater than 7.9 have 3 times higher risk for death than those with levels less than 6.3. So, normals in our labs can run up to 10 and can be as low as 4. So that's pretty impressive. There's a lot of people walking around who have been told they have normal white blood cell counts, and yet they have a much higher risk of dying when it's over 6.3. And again, this would be on repeat. This wouldn't be an isolated event. You would want to see a trend where they're running at that higher level, and that could be a sign of a lot of inflammation going on underneath. So to put this in perspective, a high cholesterol raises your risk of dying by 3%, yet you're considered healthy when your white blood cell count is 8.1. So that's something to consider, and maybe make sure you scrutinize your white blood cell counts more intensely. RDW, what I used to call the forgotten variable in the CBC. Harvard had done studies that showed that the highest quintile of RDW compared with the lowest had a 134% increased risk for cardiovascular mortality and an 88% increased risk of death due to cancer. So abnormal red blood cell distribution can be an indicator of an early indicator for cardiovascular disease, cancer, and early death. And this significance remained even if the person's CRP level was normal. So that's pretty impressive. Myeloperoxidase is an oxidative stress marker of the endothelium, so is F2 isoprostane. And you can see that those are actually even manifesting very early on in the atherosclerotic process. And then serum ceramides, basically, I think, run through the Mayo Clinic, help you assess for any acute risk for a cardiac event. So how can we make a difference? And I've heard this quote from Benjamin Franklin since I was in elementary school, an ounce of prevention is worth a pound of cure. And I'm curious if the conventional medicine world has heeded its significance. It's easy to know when to start secondary prevention, but we're not looking in the right place, and our timing as clinicians is off, in my opinion. If we're to make any progress in saving lives and helping people live longer and healthier lives, primary prevention is key, and identifying the root causes of serious illnesses years before a diagnosis or an event, this is where we can make a big impact. So not everybody wants help, and hopefully as we become more vocal and educate the public about how important primary prevention is, and I think more people are learning this, that's where we're going to make a big change. And as for our patients, our practices as healthcare providers, really primary prevention has to become part of everyone's life. So preventive strategies and goals where you need to educate, we need to reduce inflammation, we need to support the mitochondria, we need to, in my opinion, I think we should work on reducing medication regimens, and this way we could also reduce side effects, and most importantly, reduce events, meaning dying, heart attacks, strokes. So the following will be an outline of actions, recommendations, interventions, primary and secondary interventions for cardiac patients, but really this applies to all people at risk of all inflammation-based diseases. So Thomas Edison had said that the doctor of the future will give no medicine, but will instruct the patients in the care of the human frame, in diet, and in the cause and prevention of disease. Wise man. And really, we could talk about all of these factors, but education is the key, not only in heart patients, but really in all patients. So diet. So if we're going to clean up the body, first we have to clean out the kitchen. And when you eat and drink, what you eat and drink has a big impact on your health. So 3 square meals a day, 4 meals a day, a snack. This can take your body up to 72 hours to process. And eating large, frequent meals, and if you tend to have a low transit time, you're allowing for fats to turn rancid, carbs to ferment, proteins to putrefy, and you're creating a lot of inflammation that your mitochondria are trying to overcome. And 90% of the energy is going into digesting 10 times the food we actually need. So hunger, and an important thing here when you're educating people about diet is also hunger and thirst centers being located very close to each other in the hypothalamus. And a lot of times when people are hungry, it can actually represent thirst. So good hydration is a good idea. In essence, we need to adopt an anti-inflammatory lifestyle, and we always have to remember that sugar is pro-inflammatory. Insulin is it regulates growth and repair, and it does this through the mTOR and the AMPK pathway, respectively. Increased insulin leads to growth through stimulation of mTOR, which is beneficial when we're younger, but autophagy becomes more important as we get older and is triggered by decreased insulin levels, leading to repair through stimulation of the AMPK pathway. This, along with activation of the certain FOXO pathways, stimulates longevity genes. This association of low insulin levels is really the impetus for 1 meal a day regimens that people follow, intermittent fasting, time-restricted eating, and this is how these eating habits can impact people's health. The Ornish diet, which was and still is very restrictive, had been very successful because it tried to plan people's food intake so that we would limit damage. The thinking being that if you increase your repair capability so you can catch up with the inflammation that's being induced by every meal, you can catch up on the backlog of repairs that your body needed. But that restrictiveness really made it hard for people to comply. So is eating 3 meals a day good? Is eating 6 meals a day better for reducing inflammation? And I would say neither. The strategy is to reduce meal loads and frequency with as long a pause between meals as possible to allow for reduced oxidative stress and mitochondrial recovery. You can accomplish this by cutting down portions, skipping a meal, eating organic, with a goal of 80% plant-based, 20% cheat. So unfortunately, the standard American diet tends to be 10% healthy and 90% bad for you. Diet low in sugar, rich in whole foods, high in phyto, micro, and macronutrients. Eat gluten-free, live foods, raw dairy, grass-fed beef, avocados, nuts, Brazil nuts, sesame seeds, pumpkin seeds, green leafy vegetables, colorful foods, and most importantly, use a variety of spices and herbs in meal preparation, not just salt and pepper. We should all look to incorporate polyphenols into our diet, so things like resveratrol, curcumin, EGCG, oregano, rosemary, sage, ginger, bergamot, all of these can also help to induce autophagy, so don't be afraid to spice it up. Does the expense of eating organic make a difference? And that's a little, I guess, jibe as to some of these stores that don't always carry organic, and yet they claim to be organic, but it's a decided yes. So as long as you're confident that you're getting organic food, I think there is an advantage. Organic means that the food is being grown in soil with a diverse range of nutrients and minerals, and livestock have also received this benefit, as do we when they graze on the grass and live outdoors. So non-organic means using synthetic or chemical fertilizers, chemical herbicides and pesticides, genetically modified seeds, feed, antibiotics, which not only affect the livestock's biome, it affects our biome after we eat them as well. You could see all the additional nutrients that usually come with a conventional strawberry nutrients, but really the boring old, organic strawberry only has one ingredient. So which would you rather eat? Eat real food, I think would be a good idea. Get your electrolytes and vitamins that way. You can probably get all the B vitamins you need from eating animal meats, nuts, seeds, plants, and vegetables. And again, the herbicides and the pesticides are really problematic. Glyphosate can bind minerals, can alter your innate biome, and so can atrazine, which is a pesticide that's been implicated in this as a gender bender. So oils, avoid vegetable oils, avoid seed oils. Olive oils are made up of omega-9s, and it's okay to use olive oils when you're cooking, but only saute. If it starts to smoke, you're not using olive oil the right way. Coconut oil and avocado oil is okay for frying if you have to fry. Blackcurrant seed oil is a great alternative, and it's very important to focus on the omega-6, omega-3 ratio. And it should be somewhere between 5-to-1 and 2-to-1. And salt. Salt is something that we talk about quite a bit in our practice, especially in people who come in with high blood pressures. And it was reported in a study in 2011 in the Journal of the American Medical Association that the lowest risk of death for sodium excretion between 4 grams and 5.99 grams per day suggests that higher salt intake improves longevity. So they looked at people that had a no salt added diet or added salt, and they lived longer. And people with type 2 diabetes were more likely to die prematurely with a higher all-cause and higher cardiovascular mortality on a low-salt diet. A Harvard study also showed low-salt diets and immediate onset of insulin resistance. So that was curious. So I try to tell people you don't have to limit your salt intake. And in fact, it might be a good idea to increase your potassium intake and maybe mix some potassium chloride with your sodium chloride, or use some pink Himalayan salt where you're actually getting some additional minerals that your body can use. Exercise and lifestyle, never smoke anything. I think that goes without saying. Decrease your alcohol intake. Try to drink half your body weight in ounces of water per day is a rule that I give my patients. So good hydration is important. Meaningful, consistent exercise can significantly impact inflammation. So this doesn't mean that you have to do high intensity exercise or start training for a triathlon, but 15 minutes a day of weight training, especially, let's say we're talking about people who don't exercise usually. I will tell them to do 15 minutes a day of weight training of large muscle groups, walk. And if they're going to do any high intensity training, like the ball bouncing technique that you're seeing here, you do that for 4 minutes. If you have to do it, you do it for 1 minute continuously, take a break, and then another minute, and do it for 4 minutes. And you're going to get a lot of benefit and start that mitochondria really receiving the benefit of that exercise. You want to avoid sarcopenia. So the importance of aerobics, I think, has sort of waned to a certain degree. I think it's important to build muscle, and it could be really one of your most important endocrine organ could be your muscle that you're bringing more blood flow to and you're enlarging. And then, of course, stress management techniques can also be very important. Dental recommendations, knowing how important that the mouth can be and how expensive healthcare is when you develop an illness. Obviously, you want to put your health where your mouth is. So some good habits would include warm salt water rinse, brushing, flossing, water picking, cleaning your tongue. A major cavity producer being Streptococcus mutans gets killed by iodine oral rinse. And really, very few of the other oral rinses on the market can do as good a job as an iodine-based oral rinse. Omega-3 fatty acids can tighten your gums. Ozonated water rinses have been used. But alkalinity is the key. As we said, acidity really creates health problems, and the bacteria that love to live in that plaque and in that gingival disease really love acidity. Detoxing. So, we can talk about bowel movements, and that gets most 5-year-olds giggling, but adults cringe at that thought. And I have to tell you, it should be part of our daily practice to talk about this. If you're not excreting what your body considers waste, you're not allowing the opportunity for your mitochondria to recover. You're also allowing a big opportunity for whatever's been bound up and conjugated and marked for waste. You're allowing that to break down and get reabsorbed. Therefore, you're doing twice the work because you're not having a bowel movement. People should be having 2 bowel movements a day, and if sick, maybe more often. So detox definitely includes being able to have bowel movements, and going through a detox regimen without having bowel movements, I think, is not a good idea. So hydration, sweating, colon cleansing, juice fasts, blood cleansing, liver cleansing, fixing the biome and using toxin binders, doing oral chelation with chlorella, cilantro, dark greens, and bitters. And for people in extreme situations, IV chelation can be used as well. Supplements. So magnesium is a very important element in our body, and humans tend to be deficient. We can't actually make magnesium. We rely on our intake for this. And greater intake of magnesium has been associated with lower levels of inflammation and lower levels of CRP, IL-6, TNF-alpha activity. Magnesium is one of the best ways to lower inflammation. It can cause hypertension when you're deficient in magnesium, and it's a potent vasal relaxer, skeletal muscle relaxer, cardiac muscle relaxer, and smooth muscle relaxer. Zinc and copper supplementation has been associated with decreased inflammation in populations that are prone to zinc deficiency. And there's a zinc to copper ratio that we all have to be cognizant of. And ideally, you want that ratio to be 10-to-1 zinc to copper. Vegans tend to be very high in copper, and meatitarians tend to be high in zinc. So be aware of that when you're taking your diet histories. And then selenium is a supplement. Supplementing selenium has been associated with reduced inflammation and better patient outcomes in a lot of conditions. Calcium really should not be supplemented without vitamin D. In fact, vitamin D alone can increase your calcium levels. And calcium ingestion, excessive calcium ingestion, can definitely be tied to an increased risk for myocardial infarction. B-complex supplements should be dosed multiple times a day. CoQ10 supplementation would be good. And then phosphatidylcholine supplementation. So as we get older, our sphingomyelin to phosphatidylcholine ratio starts to increase, and this tends to promote calcification in plaques and instability in the plaques. And increasing your phosphatidylcholine intake will actually reverse calcification and help to reduce inflammation. Nitric oxide has important autocrine and paracrine effects in the myocardium. And it can modulate cardiac and coronary function. And there are things that can boost your nitric oxide levels, like BH4, arginine, and citrulline, which are substrates for nitric oxide. But with arginine, you got to be careful with excessive supplementation because it can actually bring out viral eruptions. SAMe, resveratrol, omega-3 fatty acids have a panoply of benefits for your health. The best source tending to be cold water fish. It's essential as a component for neuronal membranes. They can lower triglycerides. It could dampen inflammation, and they could be a blood thinner to some extent, and they can have an effect on lowering plasma homocysteine. Again, we talked about omega-6 and omega-3 fatty acid ratios. And just so you can see the benefits in non-cardiac disease, a ratio of 2.5 to 1 has been tied to a reduction in rectal cancer proliferation. 2 to 1, you suppress inflammation in patients with rheumatoid arthritis. 5 to 1, it has been beneficial in patients with asthma. 10 to 1 had adverse consequences. And a ratio of 4 to 1 was associated with a 70% decrease in total mortality. So omega-3 fatty acids are important. And one that many people used to take at a young age, cod liver oil, is a great source for DHA, vitamin A, vitamin D, and a spectrum of vitamin E. So that's maybe you want to mix your fish oils and your cod liver oils and maybe even your flaxseed oils when you're looking to work on your omega-3 and omega-6 ratio. There are actually supplements that support mitochondrial function, like fulvic acid, humic acid, B-complex, alpha-lipoic acid, CoQ10, digestive enzymes. Hydration is important. And then, of course, vitamin D is very important. And I wrote quite a few things here, but vitamin D is important in the activity of 229 genes. And it's used in every cell, every time DNA is being transcribed. Vitamin D levels are involved in suppressing pro-inflammatory prostaglandins, inhibiting NF-kappa B, and usually the half-life of vitamin D is around 15 days. And high levels of vitamin D are important for most disease states. And I do try to push my patients at least to about 60 to 80 on their vitamin D levels. Also, when it comes to vitamin E, be careful to always take the spectrum of vitamin E and not just the gamma tocopherols or the alpha tocopherols. Really, all of them are needed, and you should not try to push more from one than the other. And then, of course, there's this Pauling therapy. Linus Pauling had described this many years ago, and it's been picked up by the functional medicine realm and has been tweaked to some degree. But these are protocols that people can follow. The theory being that damaged arterial walls where a plaque is attaching, and when you want to heal, you're trying to basically compete for that attachment site by trying to heal the vessel underneath. And when you do this, the plaque's going to regress. And people have touted some tremendous results, but as you can tell, it's a very complicated regimen, and compliance is definitely needed to follow such a protocol. Vitamin K is an essential fat-soluble vitamin. K2 is a very important one because it can actually put calcium, take it away from the arteries and put it into the bones. So it's a good way to cause calcification regression. And in the Rotterdam study that was performed with K2, people with high intakes of K2 were 52% less likely to develop calcification of the arteries and 57% lower risk of dying from heart disease over a 10-year period. A Dutch study that studied 6,057 women found that participants with the highest intake of vitamin K2 had a much lower risk of heart disease. And for every 10 micrograms of K2 they consumed per day, the risk of heart disease was reduced by 9%. That's pretty impressive. And so look for those formulations out there where they combine vitamin D and K2. That might be something you would want to put into your own regimen. So these are my general primary preventive recommendations. These are things that I'm probably going to be telling everybody when they walk into my office, whether they have cardiac issues or not, when they're asking me what can be taken at baseline beyond their usual multivitamin. So I think talking about holistic approaches is important. There are a lot of holistic remedies out there that have a big impact on blood pressure and cholesterol lowering. And I list a few here. So hawthorn can regulate your heart rate. It's a positive inotrope. It's a negative chronotrope. Motherwort can also regulate the heart rate and a positive inotrope and negative chronotrope. Red clover can be a natural blood thinner with proteolytic enzymes. Adaptogenic herbs for stress reduction and alertness. And nitric oxide can be boosted through use of royal jelly and spirulina. Essential oils can also be helpful. Rosemary can raise your blood pressure. Lime and grapefruit essential oils stimulate dopamine and activate lipolysis. fenugreek and oregano and olive oil can decrease sugar. And there are also some aromatherapies that can be used. So this is an interesting little machine that we use in people who are resistant to anti-anginal medications, who can't undergo angioplasty, who can't go bypass surgery to treat their anginal symptoms. And we could also use it in people with heart failure as an adjunctive therapy to the slew of medications that we usually put them on. And so in the cardiology world, this is called the cardiac Iron Maiden, but it's not that torturous. And as you can tell, they fall asleep. But this is an interesting therapy. It's got to be done 1 hour a day, 5 days a week for 7 weeks, and then you reassess. And we can actually have memory effect, meaning the anginal diary starts to get significantly better after the 2nd week, and will remain throughout the therapy, and sometimes can remain up to a year after EDCP therapy in these patients who are really on a lot of medication and are not candidates for intervention. And it also improves heart failure patients' course. Ozone therapy, which is another adjunct therapy under the right circumstances, intravenous ozone therapy can be used. It's an immunomodulatory, and it supports mitochondrial function. And it's most useful with chronic degenerative diseases like diabetes, atherosclerosis, COPD, Parkinson's, and Alzheimer's dementia. So peptide therapies are interesting, and believe it or not, we've all been using them for many years. But this field is growing tremendously. Peptides are natural substances that influence epigenetics and behave directly and indirectly as signaling agents. So your body has 20 different amino acids that it needs, and 9 of them are essential because it can't produce them from other amino acids. And peptides are made up of multiple amino acids, and there are more than 7,000 peptides in the body. And all the body's doing, and what people are doing now artificially, exogenously, is rearranging the order of amino acids, and are able to create peptides that can delay cell senescence, modulate inflammation, boost cellular autophagy, optimize mitochondrial function, reestablish cellular efficiency, and metabolic flexibility. And so they can be used to slow down aging, believe it or not, elongate telomeres, so essentially reversing the biologic clock. What you're doing is you can actually reduce inflammation, and you could boost mitochondrial function. And they have a lot of other uses outside the inflammatory realm as well. So this is an agent that's a peptide called MOTS-c, and what's interesting about it is it can decrease insulin resistance. It's an AMPK activator, but works on the muscle primarily, not on the liver. It's an exercise mimetic, and its signaling improves cardiac function. It has exercise-like effects on inflammation, myocardial apoptosis, angiogenesis, endothelial cell proliferation, and migration, especially in diabetics. It increases mitochondrial biogenesis. And what's interesting is this has been used in the long-haul COVID world because it's been sort of seen that it's mitochondrial insufficiency or mitochondrial dysfunction that that is behind a lot of the long COVID symptoms. And this has been very helpful in patients with long COVID, really getting them out of that cloud. There's growth hormone releasing hormones, which are dosed subcutaneously and have the ability to improve beta oxidation of fatty acids. They increase the efficiency of oxidative phosphorylation. They can activate PGC1 alpha and PPAR gamma, and they modulate the physiologic levels of PGF1. And then there's xenomodulators, which these are thymic peptides that have they have the ability to improve natural killer cell function and number. They stimulate glutathione pathways. And these are agents that we're going to tend to use more in a highly inflamed state. But TB4 also has the ability to improve healing through its effect on actin and profiling. SS31 is another agent that that's a peptide that can scavenge mitochondrial reactive oxygen species. It improves insulin and cholesterol, and it reduces NF-kappa B and TNF-alpha. Low-dose naltrexone. So there may be some uses in the cardiac realm given its ability to dampen the inflammatory process that leads to cardiovascular disease. LDN is able to do this through its antagonism of toll-like receptors. The toll receptors play an integral role in the innate immune system, and the D-isomer of LDN binds to toll-like receptors. LDN reduces the production of pro-inflammatory cytokines through its effect on NF-kappa B when TLR4, 7 through 9 are activated, and it modulates release of T4 helper cells so that the immune system can respond appropriately, but not in an overactive way. It disrupts the signaling cascade, which reduces TNF-alpha and interferon beta synthesis. And aside from that, LDN is also a potent antagonist of opiate receptors, which leads to increased production of endogenous endorphins, which also have immunomodulatory effects. So toll-like receptors are transmembrane proteins, and they're expressed by cells of the innate immune system, and they recognize microbes, and they activate signaling pathways that launch immune and inflammatory responses to destroy invaders. This family of receptors plays a fundamental role in the immune response, and they're associated with autoimmunity, inflammation, and cancer. So from a cardiac perspective, it's the NF-kappa B activation, which is a hallmark for chronic inflammatory diseases, that's important. But it's not clear whether this can be done from a cardiac perspective directly. So LDNs inhibit TLR4, which leads to downregulation of the immune response, suppresses cytokine-mediated immune system, and suppresses NF-kappa B and downstream inflammation. And I was able to find a study where they studied rats and were activating TLR4, which induced cardiac inflammation, myocardial dysfunction, apoptosis, and fibrosis. And in this study, reducing TLR4-mediated fibrosis and apoptosis was something that seemed to be beneficial in reducing these effects of TLR4. And TLR4 also is the principal LPS receptor. I guess what I'm trying to say here is I'm not sure that TLR4 is playing a role in the heart. I haven't been able to find studies with humans and TLR4 in the heart. I would welcome any studies you could send my way that show that TLR4 plays some sort of a role in cardiac pathology. However, if we can do anything to reduce inflammation in general from whatever other cause, the inflammatory cascade obviously plays a role in coronary artery disease. So I think that's where LDN can definitely play a role. It seems that TLR1 and 2 has been implicated with regard to non-celiac gluten sensitivity. But if LDN is not having an impact on TLR and TLR1 and TLR2, how can it be used? So it's clear, like I said, LDN can definitely be useful in dampening inflammation, but we might be needing to use LDN very early on, maybe years before cardiovascular diagnosis is being made, since it has a powerful impact on leaky gut and the cascade that's induced by LPS. I hope I've shown enough provocative information to change how people think about their healthcare and how primary preventive strategies are important in any future breakthroughs for human longevity and good health. And again, I think primary prevention is key. The key takeaway really being that the secret to reducing cardiac mortality lies in understanding that silent inflammation triggers a chain of events years before leading to a diagnosis of heart disease or other illnesses. And in knowing that and teaching that, I think we can make a big impact. And that's it.